So this talk's around apples and oranges, which is around the topic of crazy versus mental illness, because as you know, as we all do when people are acting in strange and peculiar ways, we go, "You're crazy," you know. And actually, you know, crazy's okay. Mental illness is a totally separate thing. And in fact, experience would sort of tell me that most people that are crazy are not mentally ill. Because it's actually when you stop to look at crazy behaviour, it's kind of understandable once you get the context, whereas with mental illness it can be quite tricky. We could use this classroom, so just count 1, 2, 3, 4, 1, 2. If there's 20, 30 people in the room, 5 or 6 of us are having a hard time. The trouble with teens, they're very sensitive as their future is uncertain, and their overriding fear or thing they're trying to protect against is that it's all going to go wrong. Something's going to happen and derail that. You know, they're looking at, you know, and if you think back to your own adolescence about the potential that you know, the things that you were looking forward to and things that you might have hoped for, you know, the dreams. Although it's harder in this society now with all the X Factors and reality shows, you know, a lot of these kids do think that's going to be their way out. That they are going to be discovered. You only have to look at those blooper tapes of the poor kids that sort of don't understand, they can't sing. Reality is not a friend to everybody, you know? And again, you don't have to have a mental illness to struggle with reality. But for most young people, it's like they're in this process of unconsciously aware that they're transitioning, you know, through something. But as to where it finishes and how it turns out, is not quite clear, and it needs to be protected because something could go wrong, you know. And I think that explains a lot. I mean, on a healthy, regular thing around adolescence, you can understand bullying and their vindictiveness at times towards, you know, kids with special needs or different cultures and things like that as a way of, it's just that fear of the other or that fear of contamination or something that, you know, they're worried that that's going to affect them and they're going to be, you know, come out badly because of it. So they're in this idea of trying to protect themselves from the world in order to become the person they're not quite sure they want it is, but they just know they don't want it to be, you know. I always like that thing to use that word, the line from George in Seinfeld, worlds collide, Jerry. You watch families in supermarkets and things like that, and the way that most kids, teenagers in particular, walk 10 paces off the parent, you know, and just, you know, if the parent dares to turn around and talk, don't look at me. Don't let people know I'm here with you, you know. They don't want their worlds of peers and families to collide because their peers see them one way, friends see them one way, family sees them another. And our friends tend to see us in the way that we'd like to be seen, and families remind us that we're not quite the person that our friends think that we are, you know. So hence there's that kind of conflict about keeping these things separate. So hence, changes in the environment, things, and unfortunately adolescence is all about adjustment. Every year is different to the year before. You know, getting older, you think about your own adolescence. You know, who tried cigarette smoking when they were a teenager? Yeah, who snuck out the house without telling their parents? Who did a bit of shoplifting and, you know, didn't get caught, you know? Who started to get into arguments with their parents for the first time? Girlfriend or a boyfriend, or having a kiss, or learn to drive, or part-time job. You know, there's all these kind of things going on, most of which we're looking forward to, because it means we're becoming older, we're becoming more mature, we're becoming independent. One day I won't have to listen to what you tell me, Mum or Dad. I can do it for myself. But until then, you know. Mental illness is, and look, there is always debate around this, and definitions of mental illness are always changing in terms of what the signs and symptoms are, and, you know, because can't escape the fact that, you know, homosexuality was a mental illness until 20 years ago. So sometimes it is a work in progress, but mental illnesses have a set of symptoms. They have a course, a duration, and they can be defined, particularly things like depression, psychosis, anxiety, are fairly well known, and we're fairly clear about them, you know, and we know what works and doesn't work. And what that is a combination of medication and non-medical interventions like CBT or therapy or, you know, behavioural programs and things like that. But just like any other illness, like the flu or diabetes, it can be defined and described. And as I said, most of the time we know what it is. However, young people are not adults and still in the process of developing a personality. And so these things that make us adults, like coping skills, problem solving, capacity for intimacy in relationships, and that capacity to do things of our own initiative and stuff, we're still developing and defining and learning as we go along. You put that together with that first statement around kids being very reactive to stress, to things that seem to threaten their outcome in life, and that can go a long way to explaining kind of crazy versus mental illness. Because you can have young people with a mental illness that their personality doesn't change greatly, or they might just become more sadder and withdrawn and isolated, but they don't necessarily change a whole lot. But you can end up with a screaming banshee, just because you bought the wrong flavoured milk some days, It doesn't always make rhyme or reason in terms of these over-the-top reactions. In general, the way to think about it is, and this is based on the research, looking at how young people who do have a mental illness come to be sort of assessed and diagnosed. And the first thing they found is that it often takes a long, long time, because parents often go through a phase. So the first thing they'll do is their young person starts to act differently, and what they'll say is, well, it's just adolescence. All teenagers get moody, and argumentative and irritable and lock themselves in their room. That's true, but actually kids are pretty consistent, and even kids in adolescence are fairly consistent. So the way that young person was as a child should be fairly consistent through adolescence. They shouldn't change that much. Any kind of significant change that a young person goes through that lasts more than 3 or 4 days, that's actually a worry. So yes, you might get a young person being moody for a day or two, but then they go back to themselves, whatever it was resolves. If they're still being moody and withdrawn after a week, that's actually not a good sign. That's a sign there is something more significantly wrong. So in that sense, it's not just adolescence. Secondly, they'll go, and it might be true, it's drugs. They're on drugs, And this is where you get parents who are very well-meaning and very worried about their young person, but in the old days they read diaries. Now I think they look at Facebook, and just as bad. But it's that intrusion on that young person's privacy, because they just feel so outraged, they feel so trespassed when that happens to them. But the parent, in a sense, is thinking that it's drugs and alcohol, and they may not find any evidence. So then the parent will probably switch to something like, well, they just need a good kick up the arse. That's it. I'm sick and tired of giving them the soft approach, being kind and gentle. It's not working. I'm going to kick them up the arse and get them to do it. And again, that doesn't work. And so usually we don't get to see kids within mental health services until all else has failed, until they've got to that point where the parent goes, there's something wrong and I don't know what it is. I've done everything I can and I still don't know what's going on. So at that point, now that can take anywhere from 3 months usually to 18 months in some cases. What we do know is, because they are illnesses, the longer that you have an untreated illness, the more damage it's doing. So that's the problem. It's a biological process that's taking place. And so, if it's left alone, it gets worse. It gets harder to change. And for young people in adolescence, the importance is that, yes, adolescence is about learning to socialise and build relationships and solve problems and things like that. A mental illness derails all that. It prevents all that. That development stops going like this and just goes like that. It stops. They're not going out. You can't learn to socialise from under your bed sheets. You can't learn to solve problems from within the confines of your bedroom, because they just stop doing everything. So, school's very important for young people to attend, but not only just for the academic reasons, but this is where we all learn to socialise. So if someone withdraws from that and isolates from that, they're in real danger. So for us, for instance, now again with the difference between psychological distress and mental illness, if you've got a mental illness, that is quite traumatic to a young person. It does create psychological distress. But you can have psychological distress and not have a mental illness. So what do we mean by that? Well, the things that cause most young people psychological distress are relationship issues. It's arguments with parents, it's the loss of a girlfriend or a boyfriend. It's things like moving school. And these days, more and more, based on what's happening in the feedback that we're getting from our services, it's also things like around the pressure for sex. It's the sexting, the texting and stuff like that. And in particular, it's not the boys that are being embarrassed and humiliated by photos being shared with all their peer group of them naked or topless or having sex. The boys tend to get, positive regard for that. The girls get reputations of being sluts and, and just as an interesting side issue in terms of bullying, when you look at the gender differences between the bullying. So boys, when they get bullied, tend to get bullied on their sexuality. So they're gay or they're homosexual or they're puffs. Whereas girls get, bullied on their morality and their ethics because they're sluts or whores and things like that. It's a very different attack on that person and it's a much more intrusive and damaging thing to be told you're, as a person, you're worthless or, below worthless. So most of the things that cause psychological stress, and as I said, for us, those ED figures are based at Liverpool and Campbelltown emergency departments. So we actually had probably just over 600 presentations for that whole year, because I think that's mainly the in-hour ones, but 80% were just based on relationship breakdown. And even for those kids, though, the problem is for young people that do that, they still get suicidal, they still want to self-harm, they still take overdoses, and they still need sometimes a day or two in hospital. The difference is we can usually intervene and prevent a readmission or a relapse for most of those young people in just maybe anywhere from 1 to 2 or 3 weeks, counselling and stuff, and they won't re-present. Whereas with someone with a mental illness, depression, for instance, an episode of depression in a young person, it usually lasts 18 months to 2 years. And so not only is it that the presence of that depression in that person's life there for that time, it may be a lifetime illness, so it could relapse every, who knows, 5 to 10 years. And the 18 months that that's on, it's really slowing down their development. Again, so their emotional age may not be, they may come out at 18, but actually they're still more like a 16-year-old, and they may have missed 2 years of school. I mean, they can make it up, but it's a hard job, it's a hard work, And I can remember just through the benefit of having young people, as some of the teachers here would, young people who come back to visit us after they've been away, quite often you see a big difference. They might come back after a year and they don't look that much different. They might come back again in another year and they look a little bit different. And occasionally you get the odd one that comes back, 3, 4, 5 years later and they look enormously different. They've really suddenly like whoosh, picked up again and they're almost back to where they should be, or they are back to where they should be. So again, the good news is, I guess if you want to say there's good news, and there is good news, is that even though a thing like mental illness, anxiety or depression or panic attacks and stuff like that are a real threat to their growth and development, with the right treatment and the right support, they can overcome it and they can get back to a point where they're, the same as everybody else. As I occasionally tell them, I say, well, good, you've done really well. Now you're just as neurotic as the rest of us. You get to look after yourself. Diagnosing, it's difficult even for the experts because you have two different things at work. One, you have adolescence. Adolescence is a time of transition. So as we all know, teenagers change from year to year. They have different, and hopefully most of them are in a kind of a forward way. They're getting this strength of personality and character. But, if not, they're still going through biological changes year to year. Secondly to that, illnesses have their own course and onset. So quite often, for instance, in psychosis, what you see in psychosis is you might see, or even mood disorders, and certainly Rivendell has quite a few examples, we might see a young person at 14 presenting with depression. And I remember when I used to run groups with young people with mental illness, and you'd say, how did you know when, what was the first thing you kind of realised when something was going wrong? And 90% of them would always say, I just felt sad. I don't know why, but I just felt really sad, and I stopped going out and I just stayed in my room, you know. 6 months, 12 months later, suddenly they're hearing voices as well. So for whatever reason, and again we don't understand, but quite often the first sign or symptom is depression. Now the difficulty is, if that young person comes to see us, most doctors or people think they've got depression. And sometimes we find out the hard way that actually they've got a mood disorder, because with certain young people, if you give them an antidepressant, they have what we call a rebound mania. They go from being depressed to having a perfectly good time, you know, and feeling wonderful. And I don't need you anymore, I just need to go out and dance 24/7 and I'm fine, you know. In other words, the medication that we give them for depression actually has a reverse effect, and it lifts their mood so much, what becomes obvious to us is they have a mood disorder. So you can't give them antidepressants anymore, you know. Again, that mood order can still change again, in some rare cases, into a psychosis in another 2 or 3 years. So quite often, because of the way that mental illnesses have their kind of etiology, we may not actually be 100% certain about what is wrong with that person until their early 20s, before the illness really comes to a halt and we know what we've got. So, you know, our psychiatrists and clinical psychologists and psychologists, they know this already. And that's why I think, you know, that the kind of diagnostic practices that we have are pretty good, because we have to use a label because we need what we call a working hypothesis. But the good clinicians understand that that's your working hypothesis at this time. It may change because the way the young person presents may change, and what is happening to them may change. So, you know, we like our diagnosis, but we don't get sort of attached to it as that this is the only thing that can be wrong, because we know quite often it can change into something else and become something else. Hopefully, you know, we get to sort of understand that. Assessments take a long time, usually actually 3 hours. It's more likely 3 to 4 hours. We like to see the whole family. The reason why we like to see the whole family is because you want mum and dad's history. So, for instance, we know that if there's a first-degree relative with a mental illness, which is a parent, then the chances of that young person having a mental illness are much higher. If you've got both parents with a mental illness, you know, 50-60% of the time, that child will have a variation of that mental illness as well. Second-degree relatives like grandparents, aunts and uncles, again, they increase the risk, the likelihood, but, you know, they're not sort of designated sentences, but we just know biologically the closer the relative with a mental illness, the more likely that that young person is going to have one. You know, it's just the way all the research points it out, you know. So we want to know that. We know things like birth trauma, you know, increase, in utero trauma, increase the risk of mental illness by 30%. You know, delivery trauma, things like that, developmental milestones, if they're not met, they indicate something. You know, major separations between the infant and the mother in the first 5 years of life are significant. They often are associated with anxiety and depression later on and stuff like that. Developmental milestones can tell us things like, is it a developmental disorder? You know, there's a lot of argument these days around juvenile bipolar, ADHD and Asperger's, because they share so many symptoms. It's really quite hard. Again, it's one of those things, it's pretty hard to say what a child of 5 or 6 may have when they have that hyperactivity and, you know, don't seem to listen and can't sleep and, you know, always full of energy or get overwrought, because those symptoms fit very neatly into any one of those 3 things. But then what's the right medication to use if you do use medication? Again, just to briefly mention medication, we tend to use what they call that risk-benefit formula. So what's the risk of giving a medication that may cause, you know, neural changes as opposed to not giving it, and knowing that, you know, some illnesses cause more problems as well. So there's always that risk-cost benefit going into that. Again, developmental history can also tell us things like, is it Asperger's instead? School reports are a great help when we're making diagnosis, because, you know, if you've got a child that's got sort of 7 or 8 years of schooling and they're always a perfect kid, good grades, and then suddenly it's just gone like that, That's a very clear marker in that. Previous long-term studies have indicated, classroom teacher descriptions of kids at 5 in certain areas highly associated with adult schizophrenia and things like that. Kids that are kind of antisocial and withdrawn and difficult to work with. Not necessarily in a conducty way, in that oppositional defiant way. They're more kind of odd kid that just seems, like they don't get on and they're a bit difficult and, they may still do what they're asked, but they're just like, they seem to make everyone unsettled. Medical history, illnesses, cancer, long-term illnesses like diabetes and things like that can cause problems. Or, I remember this, it was quite a funny anecdote because the boy had diabetes and he was quite oppositional as well, but he was quite likeable and charming. And but he used to play with his diabetes all the time, so his way of being oppositional was not to take his insulin. Now, unfortunately, he ended up with a number of diabetic comas. And so when we finally got around to sort of CAT scanning his brain, it is literally, as they said, Swiss cheese. It had holes in it from the lesions caused by the diabetic comas. So what that told us was that his impulse control was virtually zilch, because the frontal lobe was just perforated with all these lesions. So he was kind of stuck in that behaviour. The funny outcome of that, we thought I was working with him with the director of the unit at the time, which was Professor Joe Ray, and it was about it was just over a year after we discharged him. He came back and he was in this car, and he was really, he was coming back and he was telling us how well he was doing, he's working, and he's bought this car and stuff like that. And then 2 days later, Joe Ray comes up to me and says, "This was all he stole the car." I said, well, Joe, the important thing was he wanted us to think he was doing well, that he'd done okay, even though he stole the car. So again, what we're trying to look for is the most likely cause and problem that's going on so that we can prescribe the best treatment. A lot of the treatment's the same. Medication will vary significantly depending on diagnosis. But after that, in terms of what's needed for that young person, it's pretty much the same. So, special ed programs like Rivendell, CBT programs, things like art therapy, supportive counselling, family work, all of these things we know work well with medication. So again, in terms of a treatment perspective, we don't just look to medication for the answer. We know that a lot more is required if we're going to have a positive effect on that young person and to help them and support them. I guess, again, even though there's a lifetime of higher risk with suicide, particularly for adults, it's not quite the same with young people. And so what we find is things like suicidality and self-harm are actually not so much, associated. They are associated with things like depression and at times psychosis, but they're actually more frequently with young people more to do with that psychosocial stress, And if you think of some of the kind of significant cases that have happened in New South Wales over the years, there are things like, boys in particular are very reactive to depression or psychological insult. So, boys don't tend to self-harm very frequently, but they suicide more frequently. Girls self-harm more frequently, but have less suicidality. It's changed a bit now, but at one stage the adolescent male suicide risk was 6 times higher than girls. But then when they looked at it even more closely, it was 6 times higher in the rural areas than it was in the city areas. And the reason why was because in rural areas they had access to guns. And being impulsive, and again the research tells us quite often young people's suicidality will close down, will reduce significantly after 24 hours. So they may be genuine and really wanting to kill themselves for these short, intense bursts, but if you keep them safe for a day or two, they quite often come out of it. We just had that recently at the service that I manage out at Liverpool with a young woman there that was actually the school on the last occasion had to call the police and ambulance to take her to emergency because she was, she was reporting wanting to self-harm and suicide. So I said to the clinician involved, well, make sure you give her the full treatment. You know, like make sure she gets a proper medical workup. Really go to town, give her the whole thing. And the nice thing was, as the clinician told me later, she said, that was great because, you know, they did all the workup and they kept her overnight, did all the workup and then sent her home. And it was so not what she wanted that, you know, when mum said, right, well, the next time, you know, you get like this, we're going to do this. And the girl looked at her mum and said, there isn't going to be a next time. I'm not going to do that again. You know, next time I'll just talk to you. So again, that's solving problems. When kids think there's hope to solve their problems, then the stress doesn't get so great. These are the services that are available for the Southwest Sydney and Sydney LHD. You can find, we have our own website. Our schooling person, Belinda Cooley at Liverpool, runs that one. So it's got all the services both for this side of the fence and for the Liverpool Campbelltown area. You can find those, as well as we're putting more and more resources on there all the time. So I think we hope to put one on this year on managing self-harm in the school environments and things like that. We have a 1 number to ring, so if you ring that number from anywhere in the state, they will put you through to the nearest appropriate mental health service, whether it's for young people or adults. Headspace, of course, is available. We have this thing called access to psychologists, ATAPs, I think it is, so you can go to the GP can give you a referral to a psychologist for 6 to 12 sessions, and then, so that treatment's all Medicare. And quite often for a lot of our referrals, that's all they need, that sort of short-term support. Of course, always your GP. If really not sure, a hospital emergency department. If it's a waste of time, they'll send you on their way, but they will still contact one of our services and let us know, and we'll still follow up. So in that case, something still happens. And lastly, you know, if it's like particularly, that's the advice we have to give sometimes to parents at the home, ring the police. Because the police actually have the power to what we call schedule on the spot, and that allows them to take somebody from that environment to a hospital emergency department where they might be admitted to some place like Concord, or they might be reviewed and let go, but they can intervene at that short time. So thanks very much.